Patty. Is everybody here? Priscilla here. Priscilla, are you here? I don't see her. Oh, she might be.
She won't be here today. She says she contacted.
That's right. That's right. I remember now. And I know Azzy's going to be late. Clarissa, are you here? There you are. Okay. All right.
Sorry, yes, I'm here.
Yes, you are. And I was hunting for also, I think Azzy's going to be late. All right, everyone, go ahead and open up your quizzes and get started. Take as much time as you can. Remember, you've got 15 minutes, so that's a minute and a half or minute and a quarter per question. So just like an exam. So don't rush through it.
Mine is saying it is locked.
Oh, for crying out loud. Let me see.
Mine is also locked.
Okay. All right.
Mine as well.
Well, one of them, they're probably all locked. Okay. I think I had it opening in at 10 after, but I can change it. All right, here. All right, so it should be available now for you. Good luck. Some of you are off camera. Okay. So, so for this week, we are talking about doing that. High risk during labor and delivery. Let me share my screen. So, who can tell me, who can tell me one concept that we need to talk about this week?
Shoulder dystocia.
Okay, and which clients would we expect to see shoulder dystocia? In other words, who do we typically expect to have trouble with shoulder dystocia?
Preterm labor.
Not usually preterm labor, no. Having trouble passing through and navigating the birth canal, sometimes an anterior shoulder will get hung up behind that pubic bone.
Isn't it moms with diabetes will have a higher chance of getting shoulder dystocia with their baby?
And because the baby is macrosomic, right? You know, usually above the 90th percentile, and those babies have broad trunks, broad shoulders. So it's a little more difficult for them to get those shoulders in and get flexed up. Okay. Anybody think of another concept? I gave you that.
Placenta previa.
I'm sorry?
Placenta previa.
Placenta previa. Yeah. So I sent you that document of all the concepts for this week and where to find them in your book. So make sure you use that as you go back to your book to prepare. If you haven't looked at the chapter 17 at all to find those concepts, make sure you do that, because a lot of that might be on the test. Okay, so take a look. All right, let me see where I am. Okay, so these are all the concepts we're talking about this week. Preterm labor and birth, premature rupture of the amniotic membranes or the sac. You know, you've heard women say, my sac broke. That's the amniotic membrane. Chorioamnionitis and meconium amniotic fluid. Post-term pregnancy, labor and birth, precipitous labor and dysfunctional labor, which is called dystocia, shoulder dystocia and prolapse cord, labor induction, oxytocin, and amniotomy. We've kind of talked about that a little bit before. And then obstetric procedures that are needed to assist with delivery. And then, of course, emergencies. So let's define a preterm labor and birth. So remember, between week 1 of gestation through week 19 and 6 days is considered an abortion if lost. Okay, those babies delivered 20 weeks and beyond are parities, right? They're a parity. Some are born at 22 weeks, extreme prematurity. So any preterm, any baby born between 20 and 36 is considered preterm. Be careful, because not all preterm babies are also low birth weight. Okay, And vice versa. Not all low birth weight are preterm. If you have a client who has some chronic illnesses on certain medications, they might have a very low birth weight baby, even though they carried it beyond the 37 weeks. So intrauterine growth restriction is a term we use that to mean that the quantity and the quality of placental blood flow was not adequate to allow a fetus to grow. Okay, we're thinking of sometimes an unhealthy placenta, or not adequate blood flow, or restricted blood flow. Okay, one medication, metoprolol, is a beta blocker for hypertension, and a very common drug for post-cardiac infarction. But during pregnancy, it reduces blood flow to the uterus. So we usually take a client off of the metoprolol and put her on something like labetalol or Procardia or nifedipine. Okay. So indicated preterm birth. What do we mean by that? What do we mean by the term indicated?
It's where she is scheduled for induction, that they're gonna have her deliver the baby preterm, but in a controlled environment.
Okay, in order to resolve a problem, right? It's indicated that we go ahead and deliver baby Anna because there's some growth restriction. She's not thriving. So we need to go ahead and deliver her at 36 weeks or sooner. Okay, it's an indication that there's something that the baby is going to survive, more likely survive and thrive better after delivery. Or maybe it's a maternal risk. Maybe she's got a blood clot. Okay, and we need to go ahead and deliver the baby. Okay, or a severe infection. Okay, so spontaneous is the opposite. Okay, indicated means we're going to schedule it. Okay, spontaneous means it just happens. Something's causing the baby to be delivered early. Remember, we've talked about prostaglandins. Prostaglandins releasing the release of prostaglandins. Remember, they're like a hormone, and they come from different parts of the body. And we kind of know that prostaglandins play a big part in the onset of labor. If someone is experiencing a lot of inflammation, something's causing it, whether it's an infection or maybe it's chronic lupus or something, and inflammation is rising, then that releases prostaglandins. So that might be one reason why, if a client gets some kind of infection, she tends to go into labor. And that's usually the #1 cause of preterm labor. It's a genital tract or an intra-abdominal infection, urinary tract infection, chlamydia, things like that. But also, if there's infection in the amniotic fluid caused by group beta strep or something else that has creeped into that amniotic fluid, that might cause labor as well. Periodontal disease. When you think about the periodontal, there's a lot of blood vessels in that area. And if there's like a tooth abscess and it's not treated, it could actually cause labor because it sets off inflammation. So serious periodontal disease can actually cause labor too. And so usually we see those things between 30 and 32 weeks, infections. Other causes are the mother's uterus. The anatomy of the uterus might be abnormal. There are some women who have what's called a didelphys uterus. It's not one body, there's two bodies, and sometimes there's a membrane, so that they actually, in part, actually have two separate uteri, okay, and the baby's in one side. So the baby's restricted in growing. The other side's usually not functional. Okay, so that's going to probably cause some preterm labor. Okay, And just the way the placenta is implanted, where it's implanted, maybe poor implantation, that can also cause preterm labor. Bleeding, sometimes maternal and fetal stress. The uterus is over distended, like a twin pregnancy or a multi-fetal pregnancy, twin or triplets. Sometimes they can go early because of the distension. And then, of course, progesterone levels dropping quickly towards the end of the pregnancy can also cause preterm labor. So there's a lot of reasons, but the number one is infection. Okay, can we predict a preterm delivery? Maybe. Can we prevent? Usually not. Okay, not for very long. Okay, so there is a test we call fetal fibronectin. Fetal fibronectin is a substance that's released just prior to labor contractions. And usually the value of fetal fibronectin, it predicts who will not go into labor probably within the next 2 weeks. So the negative value is what we use. If it turns out positive, it doesn't really tell us anything. But if it's negative, we're pretty sure that she's not going to go into labor for a couple weeks. Okay, so we usually do a swab around the cervix. Okay, because that's where we find the substance. Okay, we can also for predicting and preventing spontaneous preterm, we can do cerclages if the client has a history of a shortened cervix. We can help prevent that preterm by putting a cerclage around the cervix that's too short. Okay, and then we usually take it off at 36 weeks, so she can go ahead and go into labor. Okay. We do provide prophylactic progesterone to women who have a history of preterm labor. We make that decision usually in the early second trimester to put her on some supplemental progesterone vaginally to support that pregnancy, especially if it's a cervix that's short. We also can help prevent preterm birth. Sometimes we'll put them on nifedipine to help relax that uterine muscle. So management. So knowing the signs of preterm labor, usually it's a different kind of pain. It's contractions, but she's going to feel a lot of pelvic pressure and dull back pain. Okay, and it's almost going to be like a uterine tightening. Okay, almost like a Braxton Hicks, but a lot of dull pelvic pressure and dull back pain. Okay, so if it's not due to an infection, if everything looks fine as far as the amniotic fluid, ultrasound shows baby is doing fine, and we don't detect any infections, then we're going to try to stop the contractions and use a class of drugs called tocolytics. So toco means contraction. Lytic means to lyse or to cut or to stop. So tocolytic means to contractions stop. Okay. Terbutaline is who can tell me what class of drugs terbutaline is? Who can tell me? Anybody know what terbutaline is?
Adrenergic agonist.
Okay, a beta agonist. Yes, it's a beta agonist. Yeah, adrenergic beta agonist. So what are some of the what does it do? In other words, it relaxes the uterus, but what else does it do? It's a beta agonist.
Shortness of breath, wheezing, and chest tightness.
not usually associated with respirations. We do give it for asthmatic clients, so it actually relaxes the bronchial tissues. But what's the other part of it? The other beta part. Beta 2 is the lungs, right? So it relaxes the lungs. What's beta 1? You remember the receptors from pharmacology? You're gonna have to know these for
It
med-
affects the heart.
Okay. So what does terbutaline do to the heart?
It's going to increase the heart rate.
Yeah, and therefore it's going to increase the blood pressure. Okay, so do we want to give this to a client with a history of blood pressure, high blood pressure, or any kind of heart disease?
No.
No, we're not going to give. It's contraindicated for any cardiac patients or any patient with a history of hypertension, even gestational hypertension. We're not going to give terbutaline. Okay, so our choices are nifedipine, indomethacin, and sometimes magnesium sulfate, which doesn't really drop the pressure, but it does relax skeletal muscle movement. And it's mainly for the baby. Indomethacin is anti-inflammatory, and that, along with the nifedipine, will reduce the risk of a preterm baby. If it's inevitable and she just continues to have contractions, or the medications we're using are not
Hey
effective.
Siri. Mm-mm.
What's the matter?
Nothing.
I'm going to mute you there. Okay. So if it's inevitable, and we're not able to stop labor, there are some things we're going to do for the baby. Some things we need to do to protect that baby. And in particular, the very tender, sensitive, fragile blood vessels. Okay. So betamethasone, we're going to give to mother. Okay, and that's for the baby, a steroid, and that helps to stimulate the lung maturity in the fetus. We're going to give antibiotics in case there's infection. It's a prophylactic way of giving it. And then we're going to begin some magnesium sulfate, and that is to improve the cerebral blood perfusion of those vessels. It helps the vessels widen and receive more blood. So that helps prevent against cerebral palsy. So those are the 3 things that we're doing, and they're all going to mom, but for the benefit of the baby. Okay, so magnesium sulfate, you know what it does to mom, because we use it for preeclampsia. So you know the effects that it has. So make sure you're monitoring your mother who's receiving it because she's in preterm labor. Okay. What happens if the amniotic fluid sac breaks? Premature rupture means that it has ruptured and fluid is leaking, and yet she's not in labor. Okay, that's why it's called premature, because she's not in labor. Okay, if her sac breaks and she doesn't go into labor within the hour, it's called premature rupture. But if the sac breaks and she goes into labor in half an hour, then it's not a premature rupture. Okay. So it's a spontaneous rupture. Okay. So a full term then would be a client who reached the 37th week of gestation and her membranes rupture. The problem with premature rupture, in other words, the leaking and the loss of the fluid and not going into labor, is that it sets mom up for a lot, actually baby infections. Chorioamnionitis is one coming from the vaginal tract. So once that sac is open, then that's a channel for bacteria to vertically be transmitted. Okay, so usually if we have a premature rupture and it's excuse me, and mom is, and it's been 12 hours, we need to start some antibiotics. There's no set hours when we start them, and every client's going to be different. Okay. For outcomes, also with premature rupture, there could be a placental abruption. We might see that as an outcome of premature rupture, or retained placenta after delivery. Okay, hemorrhage. And then if chorioamnionitis develops and we treat pretty aggressively with antibiotics, if we don't eradicate all that, it can actually infect the inner lining of the uterus, and it's called endometritis. Okay, so there's a risk for endometritis. And then also, what if all that fluid, if you picture a baby that has dropped down because all the fluid is gone and the baby's no longer as buoyant, if the baby's not engaged, that umbilical cord can actually drop down and become cause a prolapse. Okay. So with preterm premature rupture, in other words, if we have a preterm gestation and the amniotic fluid is leaking, the sac broke, and mom has not gone into labor yet, that's what we call a preterm premature rupture. If it's less than 34 weeks, we do an expectant management. In other words, we know what the risks are. We know what's ahead of us for mother and baby. So we have to definitely make some plans and do the antibiotics, magnesium, assessing pulmonary maturity if we want to go that invasive, teaching mom. If she's just leaking a little bit of fluid and she's preterm and she's maybe 33 weeks pregnant, we're going to try to hold off as long as possible. There's some other things that we can do. We can actually add fluid and then instruct mom about daily fetal assessment. You know, is her baby moving as much as before? So she has to be involved in the care. And then a non-stress test, just to check on the well-being of the baby. But at any time, if we suspect an infection, then we need to deliver, okay, and treat with antibiotics and everything else. So it's an expectant approach. The idea is to let that pregnancy go as long as we can let it go, for as long as baby is safe and mother is safe. Okay, so we have to watch for signs of infection, because we want, you know, every hour that we can postpone it, it's better off for the fetus. So what is chorioamnionitis? Well, the membrane, the amniotic sac itself, is really dual membranes. There's two of them. There's a chorion on the outside and then the amnion on the inside, and they're kind of meshed up together tightly. So it's like a dual layer. Okay, so chorio, amnion, they're both infected as well as the fluid. So chorioamnionitis. In this picture I have here, you can see that there's different sources that can cause chorioamnionitis. Just like an amniocentesis, something we did, some invasive procedure we did that introduced bacteria. The uterus itself might have an infection. The placenta is infected, or something in the maternal blood that has spread to the fetus. For example, herpes simplex. If mother has a herpes simplex primary outbreak during pregnancy, then there's an increased risk for the fetus to have HSV. Okay, so that's from mother's blood. Then, of course, traveling up, a vertical transmission from the vagina. So these are just the different ways chorio can develop. But so what are some signs of chorioamnionitis? They're listed here.
I'm gonna read from my notes. Fever, tachycardia, uterine tenderness, purulent, amniotic fluid, odor, color. I don't know, that's all I got.
That's great. You did it. You got them all. So those are some clinical signs. So if you were, let's say, you have a client in labor and you begin to notice that her temperature is going up and she's a little tachycardic and so is the fetus because they have a fever. If mother has a fever, so does the fetus, right? So tachycardia, that should be a couple cues for you. Oh no, does she have an infection? Her temperature's up. We've got some tachycardia going on. And palpate her uterus, and it's very tender. And then amniotic fluid begins to flow, and it's purulent, discolored, it's got a foul odor. So that tells you she's got an infection. Okay. So an infection in the amniotic fluid during labor might cause dysfunctional labor, and it might spread through the uterus into the blood and cause bacteremia, endometritis. And with the fetus, an exposure to bacteria or virus can lead to pneumonia. We see a lot of pneumonia and meningitis. Chorioamnionitis, sometimes the culprit is the group beta strep organism, the GBS. GBS is a common microorganism that sometimes people just carry. It's just present and it's not usually a problem. We don't treat it. But during pregnancy, we have to treat it because we don't want group beta strep invading the fetus. So, it can cause meningitis. Since we started doing screening for group beta strep during the prenatal period, sometimes when we check urine, it shows up in urine. If we do a vaginal culture and a perineum culture and a rectal culture to screen for it, we do that with every client at week 36 also, just to make sure the client doesn't carry GBS. And if it's positive, then we know we're going to be giving some penicillin during labor. So since we've been doing that, the evidence has shown that treatment at labor and during labor with penicillin has reduced the incidence of meningitis to just 0.1%. So it has really helped in fetal health to do that. So we do need to administer antibiotics, and we're not going to stop any labor. So if she's 34 weeks and she has amnionitis, we are not going to stop labor because there's an infection. We need to deliver the baby for the baby's well-being. Okay. So tocolytic therapy with terbutaline or anything else is contraindicated. We need to treat the baby, give the antibiotics, everything else we would do for a preterm. Any questions about that? Okay. And then post-term pregnancy. So delivery beyond 42 weeks is considered post-term. Well, what's the problem with this? Well, the larger the baby gets, the greater the problems with labor and delivery. Okay. There are some women who just want the baby to come when the baby's ready. Okay. They want everything natural, and I respect them for this. But we know from research that beyond 42 weeks, things get a little riskier. Okay. Labor dystocia. The uterus doesn't function in a normal manner. So there's trouble with progressive labor. And then, of course, injury because the baby's bigger. So lacerations, tears of the pelvic floor muscles, and then hemorrhage, fatigue. Mother gets worn out during labor and then the increased risk for a C-section. For as far as a fetus goes, baby's big, right? We've let that baby grow a couple pounds every week beyond 39 weeks, which is the most ideal week. It's been 1, 2, 3, 4 weeks. So they're growing. So there's an increase for birth injuries to the baby. Okay. Increase for cord compression because the fluid levels begin to drop. Placental function is not meant to last beyond the 40 weeks or even 39 weeks. So the placenta begins to deteriorate a little bit. Okay, it becomes calcified. So it's not functioning up to par. So it comes back on the fetus, lower amniotic fluid levels. So increased risk for the cord compression. Meconium aspiration. A stressed fetus during labor, if a fetus experiences enough hypoxia during labor, poor oxygenation, then they could actually release their first stool in utero. Okay, so hypoxia leads to vagal stimulation and then the release of stool. And so when that baby is born and there's stool all over the baby, meconium, then there's an increased risk that they'll actually aspirate that. And we talk about that during high risk OB2. Okay. Any questions about post-term pregnancy? So we do, hopefully we have a relationship with our clients during the prenatal period where we discuss her birth plan. Yes, she wants to go natural. She doesn't want to be induced. As we get closer to that 39th week, we talk about it again. It comes to week 40, we definitely need to be talking about it. And, we could allow you to go another week. If you want to do that, please do this. So we need to teach our clients to be aware of fetal movements, fetal kick counts. How many times is your baby moving in an hour? So there's no standard time, but we want them to be aware. And if they notice reduced movement, then we get them to come into the office. And so we need to be doing more frequent ultrasounds, maybe some NSTs, a non-stress test to make sure baby's still functioning well. Look at the amniotic fluid, look at everything. And so we allow her to go to maybe the 41. That's dependent also on the provider. Okay. I worked with a provider, he didn't want anybody going to 40 weeks. It was just, we induce them. And most clients do want to be induced, I think. I'd have to say most of them do. They're tired of their pregnancy and they want it to be over. Some of them tell me they're tired of their pregnancy at 32 weeks. And I don't want to say you have a long way to go. I said, well, it's a little too soon. Your text goes into all the different ways, dysfunctional, the causes, protracted. Don't memorize all that. And if you noticed on that document I gave you, I didn't go into all of that. Okay. So dysfunctional just means long and difficult. So either just ineffective uterine contractions, or there's this goes back to the 5 Ps again, the powers of labor. What helps labor progress? So when you think about that, things that cause dysfunctional labor is one of those Ps, okay? Position of the baby, the diameter of the pelvis, the soft tissue. Maybe she has a placenta previa or has had some surgery in the area and the tissue won't stretch. The way the baby's lying, maybe it's kind of oblique or breech. And the baby's position, is the baby flexed and able to travel through the birth canal, or is the head hyperextended? Because that makes it harder for the baby to travel. And then cephalopelvic disproportion just means that the size of the head, which is a cephala, and then the pelvis. and the head cannot fit through the mother's pelvis. And that's probably a lot of the causes why we do C-sections. And then just remember the mother's psychological status. If she's anxious, it's going to inhibit. Advanced maternal age, epidural anesthesia, and then obesity. And then we have some times when the baby's not in the right lie. And we can do what's called an external cephalic version. If they're in a transverse or maybe a breech, we can actually try to move the baby externally before labor. Now, this is risky, and there are some preparations we have to do. First of all, we have to get the client's permission. We need consent because of the risk associated with it. We need to, for sure, do a last-minute ultrasound to see where the baby is, what position, and what lie. We might also do a non-stress test to see how well the baby is being oxygenated, the condition of the placenta. Okay. We'd also might give a tocolytic just to help relax that uterus so we can do the moving. And we're monitoring that fetal position or the fetal heart rate the whole time. If our client has Rh negative blood, then we're going to go ahead and give her immune globulin at the time, just in case there's any mixing of blood, if there's some bleeding that occurs because of the procedure. So that's your external version. I've never seen this done. The provider I worked with has never done this, at least not in the last 10 years. He hasn't done this. He just schedules them for a C-section. Okay, precipitous labor. Remember we talked about this. A labor that starts and ends within 3 hours. Goes very fast. And the problem is it's usually the uterus that's having too many contractions or is contracting too strong. The problem with that is there's not enough rest times between contractions for the fetus to regain good oxygenated blood. So if the uterus is always contracting, then the blood flow to the placenta is reduced. So you're going to see possible hypoxia develop. Okay. Hypoxia, developing can cause actual brain damage. And then of course, any kind of trauma, transgress or traveling through that passageway can actually cause brain damage from trauma. Okay. And of course, for a mother, it would be rupture of the uterus, laceration, and hemorrhage, definitely hemorrhage. Postpartum hemorrhage is a risk factor. Hypertonic contractions, uterine tachysystole can also be seen. You'll see that if you have placental abruption, it could have been caused by that. Or cocaine can cause hypertonic contractions and tachysystole. So hypertonic means stronger contraction, and then tachysystole means they're occurring every minute. Okay. Any questions about anything so far? Okay. Anybody want to take a break? Okay, let's take a break until 15 after. I have 3 past the hour. I'll give you a good 10-minute break plus a couple of minutes. So, and I'll see you back then. And we'll do some other things and watch the rest of this.
We can't hear you.
I thought I turned it on. Okay, my finger's too fast. All right, so let's talk about labor induction. So we have a 41-week client and we need to induce her. We need to have her labor now and not wait any longer. Okay, so our plan for labor induction is like 2-step at least. Okay, so first step is that we need to determine the condition of her cervix. We cannot begin labor on someone if their cervix is closed, is still firm, and is not ready at all. Okay, so we're going to assess the condition. So with a vaginal exam, we're going to check, does the cervix feel firm still, or is it beginning to soften up even more? Is it beginning to shorten or efface? Is it dilated at all? And then what position is it in? Usually what I find when I do an exam, if the positioning tends to rotate from posterior to anterior, the cervix does, as labor begins or as she gets closer to labor. So where is the position of the cervix? And then fetal station, where is the fetal head in relation to the ischial spines, mother's ischial spines? So in other words, where is baby as far as the descent? Okay, so the softer the uterus, the more anterior, the more effaced, and the more dilated, and the lower the baby is, the more likely that induction will take place successfully. Okay, so we use the Bishop score. It's a instrument. It's got those 4 parameters, and we give numbers to each one. For example, if the cervix is anterior, it's dilated 3 centimeters, it's soft, and the baby is dropped down at the ischial spines, things like that, then we know we're ready for labor and we don't have to prepare her. But if it's less than 4, 5, and there's no set number, but 4 is a good number. If you come up with only a 4, her cervix isn't ready. Okay, so step 2 would be, well, what can we do to get that cervix ready? What can we do to ripen the cervix? Most commonly, we use medications, prostaglandins. Okay, so prostaglandins will cause that cervix to efface and dilate. So usually the scenario is this. She's 41 weeks pregnant. She's in the office. We're going to have her go to the hospital that night. We're going to put some prostaglandin gel or a prostaglandin tablet inside, behind, or around her cervix at bedtime. And so we're going to do that every 4 hours. If we're using gel, we're going to replace the gel every 4 hours and monitor the cervix. The next morning, in reassessment, if the cervix is now more inducible, in other words, it's like a 6 or a 7 now when we do our assessment, then we can begin with the actual induction. Okay, sometimes we start with an amniotomy. In other words, breaking the sac. We do an amni tool. Okay, we'll just go in there and break the rupture of the membranes, and sometimes that helps labor to progress quickly. Okay, so when we begin induction, we're using oxytocin. Okay, so we're starting an IV of just plain a normal saline. Okay, get that going if it's not already going from the night before. And then we're going to hook her up to all of our monitors, monitor the baby, monitor any contractions, and then we're going to plug in the oxytocin to the primary line. Okay, so oxytocin will start uterine contractions. Okay, oxytocin does a lot of things. Okay, uterine contraction and breast milk ejection. Okay, it has a very short onset of action and a very short duration. So we give it in a continuous infusion. Okay, So in this picture, it shows 30 units, and this is a liter. Oh, actually, this is a 500 ml bag in this picture. So you have to do your calculation. And most OB nurses know what the rate is right away because they've done it so much. For 30 and 500, I know what that is. And I have a chart that shows me if it's 30 and 500, or if it's 30 and 1,000, what's the rate I need to run it at if I want to give 2 milli-units. Okay. So oxytocin is used for labor induction. It's used for if a woman goes into labor naturally, we can use oxytocin to make those contractions more effective. Okay, so we're augmenting labor. It's also used postpartum to help stop bleeding. Because remember, it causes contraction, which squeezes all those blood vessels. Okay, it's a high alert drug. And it's best to always double check your pump program, how you programmed your pump with another registered nurse. Okay, because it can cause uterine tachysystole, too many contractions, which can lead to a uterine rupture. It can cause placental abruption, and of course, hypoxia, and then infection. Okay. So the next slide is just how I set up oxytocin and how I calculate it. So in your second OB calculation, you were required to do this. Okay. So I don't do dimensional analysis, but it's easy enough. If you want to plug that in, you can do that. So in this scenario, there's 20 units in 1,000. And the very first thing you need to do, and some of you didn't do this in your calculation, convert the units to milli-units to avoid any mistakes. Okay, you're not going to be prescribing per unit, you're prescribing milli-units. Okay, it's a very potent drug. Okay, determine how many milli-units is ordered and then go from there. And then you have to multiply that by 60 minutes. It's prescribed milli-units per minute. But in order to get your pump going, you need an hourly rate. So you need to multiply that number by 60. Okay. And then here is the titration that we did. And then hemorrhaging, we're going to use a whole lot more. Okay, we're going to give 500 milli-units a minute. Okay. So let's talk about, we've got our oxytocin going, contractions are nice and regular, babies or mothers having good progression in labor, and we get to the point where we're in the transition phase and mom is fully dilated, getting ready to deliver. But the baby is having trouble getting through that last little bit. Sometimes we have to make a decision to use a vacuum to help. So we apply the vacuum during a contraction and during mother's bearing down, okay, to assist with the delivery of the head, okay. In order to do this, of course, she has to be fully dilated, fully effaced. The membranes have to be ruptured, and the baby's head has to be engaged beyond the ischial spines, okay? And we know for sure that there's going to be no problems with delivery. And of course, vertex, that means this is the presenting part of the baby, the vertex of the head. If the face is presenting, we can't do it. Okay, so anytime we use something like this, there's potential for injury to mom and baby. Okay, hematomas, lacerations, cephalohematoma, which is a hematoma on the fetal head, subdural hematoma, scalp lacerations, And anytime there's bleeding in a fetus, then you got to worry about bilirubin levels. So there are injuries, but this is the most safe, the safest way to assist mom with delivery. The other option are forceps. And if you have a prolonged second stage, in other words, during fetal descent, if it's slow and prolonged, sometimes we need to use forceps. So these are devices that are wrapped around the newborn's ears and cheek area, this whole area, okay, as you can see in the picture. So this helps us not only during pushing for the baby to descend, but also helping that baby to internally rotate and then hyperextend. Okay, so abnormal presentations. If it's if the presenting part in your palpation is a face or the top of the head, then we can help position that head correctly. Okay. We can always use it also for a breech presentation, which I think I have in the picture down low here, where we're supporting the body and then helping to deliver the head this way. So down here on our heads underneath is the facial nerve, right? It's one of your cranial nerves. The facial nerve innervates the face as far as smiling, frowning, things like that. So if there's pressure against that facial nerve, it could be damaged by using forceps. It's usually not a permanent damage, but the baby might have some palsy, facial palsy because of this. Okay, so that's a risk we take with that. And in this picture, this baby doesn't show any palsy, but you can see where there's a little bit of abrasion there from the forceps and a bruise. All right. So yes, anytime we use an instrument, a risk for injuries. Okay. Mother's bladder being damaged, and it can cause bladder lacerations, urethra damage, urinary retention, hematomas, vulvar hematomas. So your book talks about, it's called Vaginal Birth After a C-Section, and then Trial of Labor. If we have a client that had her very first pregnancy was delivered by C-section, we don't really like for her to deliver with the next pregnancy vaginally because of the scar on the uterus. There is some risk of that uterus tearing and rupturing because of the cesarean scar. And it depends also on the kind of incision that was performed on the uterus itself. Any kind of classical vertical incision, we cannot do vaginal delivery. Okay, we cannot do a vaginal delivery because of the damage to the uterus. So we have to do C-section every time, okay? So, but if she had a low transverse or a low vertical, sometimes a provider will allow that, okay? So what we do is we cannot induce labor, okay? So she has to go into labor on her own, and then we just monitor her for 4 to 6 hours in labor to make sure she's progressing nicely. And just let her labor down if baby's doing fine, okay? But we're not going to enhance any contractions. But if there's nothing going on after 4 to 6 hours, if there's not much progression of the cervical dilation or effacement, then the decision will be made to just do another C-section, okay? it's required or recommended that a client that had a C-section delivery wait at least a year before she even gets pregnant. We have to allow time for all that uterine muscle and fascia to heal up completely before she gets pregnant again. So that's what's meant by a VBAC. So this slide is talking about, elective C-sections. Client who had a previous one and we need to do another one is considered elective. When we plan it and schedule it, it's considered elective, right? If there's some cardiac problem and we'd rather do a C-section, like Marfan syndrome, or the client has aortic stenosis, we don't want heart rate to get too fast. We need to keep the heart rate down. We don't want any work on the heart. Placenta previa, definitely, or breach, or just the presentation of the fetus might lead us to decide to have a C-section. Okay, so nursing care plan, your role in surgery, your role for a C-section. Make sure the client has signed a consent form. She needs a consent for the anesthesia and she needs a consent for the procedure. You're not responsible for her knowing. You're not responsible for obtaining the consent. That's the surgeon's and the anesthesia role. That's their responsibility. But your responsibility is to make sure it's been done and she has no more questions. Okay. She will need to be typed and crossed, at least typed and screened for blood transfusion. And we usually do CBC and other lab work. Usually do an ultrasound. Okay. We need to apply sequential devices on her lower extremities to help prevent blood clots. And we need to put in a Foley catheter. Sometimes it's required that you do a prep and a scrub of the area before even going back to the OR. Okay. As you're doing things, getting your client ready for surgery, you need to explain why you're doing things. Explain to them what to expect. We're going to go ahead and we're going to get your epidural in or your spinal in, whatever the plan is. We're going to put a catheter in so we can monitor your urine output and keep the bladder decompressed so we don't puncture it. And so you want to explain as you go. Okay. And usually, if it's an emergency situation where we might not have time for any of that stuff, we can accept a verbal consent if it's an emergency. Okay. If it's an emergency, we can't do an epidural or a spinal. We have to do a general anesthesia. It takes too long. If we need to get a baby out, we're going to do general anesthesia. Okay. Whether it's elective or emergent, there's risk for surgery, like any other surgery. Blood clots, infection, accidentally injuring another internal organ, like the colon or the bladder, the ureter. Okay, so we worry about that. And then fetal asphyxia, respiratory distress, and blood loss to mother. So remember, during a vaginal delivery, as that baby is navigating through that canal, the chest is being compressed, which helps get rid of even more lung fluid. Okay, so when they're born, they don't have much trouble with too much fluid in their lungs. With a C-section, we tend to see a little bit of transient tachypnea because they have leftover fluid. They still have some retained fluid in their lungs. So we might see some tachypnea, breathing faster, having a little more effort to their respirations. So remember the risk associated with major surgery. And this is really true for all surgeries, except the fetal part, of course. Okay, infection. So all surgeries across the board get a prophylactic antibiotic. For spinal surgery, they get Ancef, 2 grams. Okay, cephalosporin, 2 grams. For urology, they get Ancef, and it depends. You know, sometimes they don't give the same drug, but every client that goes to surgery, at the time of incision, the antibiotic needs to be infusing at that time. Okay, that is just a standard of care. Okay, so it's true with C-sections. Okay, and sequential devices on legs to help prevent blood clots. Those sequential devices are alternating compression of those legs like this to keep the blood flowing in the lower extremities, and it helps prevent blood clots. Blood loss, of course, a liter of blood approximately lost in a C-section. And then, of course, there's a risk of some kind of embolus, and it usually is a pulmonary one. So another emergency is the meconium. See this picture of this baby? Kind of sad, but this is not uncommon with a post-term baby that experienced stress, or any baby that experienced a lot of stress during labor might pass meconium, which is what we call the very first stool, you know, intrauterine, and then they're born with it, and it's all over them, and they tend to aspirate it. So if we see meconium stained amniotic fluid during labor, your job is to notify the neonatal team, the high-risk team, a neonatologist, so that we can begin resuscitation at birth. Okay, so get the team there. It's usually a high risk. You usually have several nurses that'll show up. Respiratory will be there, and so will be the neonatologist. Okay. So what this usually leads to, if they aspirate it, is like a pneumonitis, which is inflammation of the lungs. It's really hard to treat, not necessarily an infection, but inflammation, which causes edema, and then they have trouble breathing. So this is definitely a high-risk situation. Now here we are with shoulder dystocia. So our diabetic clients, okay, we got us a big baby, okay, with broad shoulders. And when that baby is delivering and externally rotating, that shoulder gets stuck, that anterior shoulder, as you can see in this picture. And so the big baby will present and descend, and then because the shoulder gets stuck, it tends to go back inside. And so it's a turtle sign, because it bobs out and in, out and in. And so in order for that baby to pass under that pubic arch, the shoulders need to be squeezed together, and the baby's head needs to be hyperextended. Okay. In order to do that, to assist, we can do the McRoberts maneuver. Okay, and apply suprapubic pressure just above the pubic bone, and that helps gently push down on that anterior shoulder. Okay, so this is our diabetic. So a client with a macrosomia baby, polyhydramnios, going into labor, she's at risk for a C-section, she's at risk for a shoulder dystocia. Okay. And then postpartum, babies at risk for injuries, babies at risk for hypoglycemia, babies at risk for what else? One other thing. Can you remember? What's a baby at risk for? A diabetic client in particular, postpartum, early postpartum, like right at birth. Other than hypoglycemia, what's the other one?
Respiratory distress.
Respiratory distress. Respiratory distress syndrome. Yes, because hyperglycemia, lots of insulin, excessive insulin because of the resistance of the cells reduces the production of the surfactant, so respiratory distress. So you can imagine a baby that's having trouble being delivered, fetal asphyxia, fractures. Clavicle fracture is the #1 fracture. We're trying to squeeze those shoulders together, and one of the clavicles might fracture. Fracture of the humerus. And then, of course, it's called the brachial plexus injury. When you're trying to hyperextend the head, you might be causing too much traction on this nerve plexus right here, this group of nerves right here that innervate that same arm and hands. So you could cause some paralysis. And of course, hemorrhaging and the mother's body, the pelvic floor damage. There's another picture of that. Umbilical cord prolapse. So normally when there's adequate amniotic fluid and the cervix is closed, you know, the umbilical cord is free to float and it's not squeezed or caught up in anything. Okay. Once labor starts and the amniotic fluid is drained out, if the baby's head is not engaged, the cord could actually slide down between that head and that cervix. This doesn't really show it very well, but and this is a position, the breech position, it's more apt to do that. See, you see how it's coming down ahead of the baby. So this is what we call a prolapse because it leaves the uterus. It prolapses into the vagina. So does anybody remember or know what you should do? What would you see on the monitor if this was happening?
The priority is ABCs to oxygenate the baby.
How do we oxygenate the baby?
You're
Um,
gonna put the mom in knees to chest position to get compression off the head or the cord.
mhm.
Okay. So oxygenation comes through the blood flow, right?
Mhm.
If we squeeze the cord, it reduces oxygenation. So what we need to do, who was that? Kelly said, we need to reposition mother to get the baby off the cord.
Yeah.
Okay. So we can do the knee chest position, you know, have her up on her knees and her arms and elbows on the bed. Okay. And what that does, it helps the baby pull back down into the uterus away from the cord. That's the best thing you need to do in this situation. You're calling for help at the same time. So what would you see on the monitor?
Is it variability?
Variable contractions or variable decelerations. Variable decelerations. Mhm. The sharp V's that are occurring, that's a sign of umbilical cord compression or prolapse. So if you see the variable decelerations, then you need to do a vaginal exam. Go ahead and get her up on her knees and do a vaginal exam to see if you can feel the cord. But you don't want to push on the cord because you're causing decompression. I mean, you're pinching it as well. You want to push on the baby's head or the feet. And then, have to go to the ER or go to the OR. So stay with the patient, reposition to the knee chest or severe Trendelenburg with a sterile glove, sterile towel, some saline. Push on the presenting part, not the cord. Okay. And if you can, once you've done all of that and you've got everybody working to get her to the OR, wrap the cord in a moist, sterile towel. Exposed. If it's exposed, it's going to dry out very quickly. Of course, you're going to give mother oxygen, give her some more fluids. Get her to the OR. Here's some different positions. So this is the knee chest position. You can see when you move her in this position, how that baby drops down back in that uterus, and the cord then is no longer pinched. Uterine tears. This is usually associated with previous surgeries on the uterus. If there's scar tissue, it can tear away from the good tissue. So make sure you're keeping an eye on any uterine tachysystole. And be careful of your oxytocin. Make sure you're documenting and monitoring uterine contractions so that there's no more than 5 in a 10-minute period. So what you would likely see if there was a rupture and massive bleeding is the fetal heart rate dropping down and prolonged decelerations. Because when this happens, there's a lot of blood in that uterus. So when it's torn, all that blood flows backwards out from the uterus and away from the baby. Placenta doesn't get the perfusion. Another emergency is the anaphylactoid syndrome of pregnancy, it's called. It's like another embolism, but it's not blood. It's amniotic fluid. I've never seen this. Okay. But you're going to see the same signs as you would with a pulmonary embolus. Okay. Sudden respiratory distress, cardiovascular collapse, blood pressure drops, heart rate goes sky high, and then you have coagulopathy, blood clotting everywhere, DIC. We see DIC also with the abruption of the placenta. It's rare, but it does happen. So usually if we have an emergency like this and we need to resuscitate mother, the standard is that you do CPR for 4 minutes. And then if it's not successful, go ahead and start the C-section. You might still have some people doing the CPR, but we need to do a C-section to get that baby out. Okay, that's the end of the slide sets. So I've just been doing nothing but lecturing today, and that's okay. It's a lot of stuff. Is there anything about that you need help with understanding? It's probably just a matter of you going back and looking through the slides. Look at the, let me find them. For this week. Let's see here. Oh, here we go. Okay. this document I gave you, preterm labor, I went through all of it. Preterm labor, premature rupture, went through all the concepts of chapter 17 for you, and just gave you some guides as you read the book. What are things that are important? So this should really help you in going through this chapter, so you're not having to read everything. Okay, so do use that. Let's see. Be prepared, Maria, and on page 415 to 460. So we can look at your book and do the Maria case study next for the last 30 minutes of class or so. Okay, so it's on page 415. If you have your text open and your and I will pull it up here. 415 is my text. I'll pull it up here so you can see it. So we're going to go through this case study together, and you can look at it later too, because it's in your text. So we're going to. Trying to get rid of all those dots. Okay. Can everybody see this or open up their own? So we have, I don't know if you can see this or not, but Maria is 36 years old, and she's a gravid of 5, Pure of 4. So the pregnancy resulted in a term birth at 7 pounds 6 ounces. The pregnancies she's had were closely spaced, and the gestational periods of the next 3 pregnancies became progressively shorter. And then she had one born at 34 weeks. So she smokes a half a pack of cigarettes a day, 4 feet, 11 inches tall, and weighs 96 pounds. Had a divorce and all of that. Maria appears to have little understanding of preterm labor, its causes, and its prevention. So a few days later, Maria tells her neighbor that she has a backache and she's feeling lots of pelvic pressure. She says, quote, "It feels like the baby is balling up in there," end quote. Maria noticed a larger amount than normal of clear vaginal discharge this morning. For the last several hours, her tummy tightening is regular, although she denies pain. And her neighbor says, "I think you might be going into labor." So what are some signs and symptoms that Maria may be experiencing preterm labor? Can you see this, or are you looking at it? So which ones? Just go ahead and shout them out. What you think?
A,
Which one?
D,
A? C?
and B.
D, and E.
D? E? Sometimes, yes, painful contractions. Sometimes not. Okay. Maria contacts her provider and is advised to drink more fluids and get some rest for several hours. Her mother comes over to watch the children, and after several hours of rest, Maria's symptoms subside. Sometimes women will have early contractions because they're a little dehydrated. If we give them some IV fluids, they go away. Okay, so sometimes that's what we try first. Okay, the following day, Maria visits her health provider. Her cervix is closed and she has no symptoms of preterm labor. The nurse and Maria discuss a plan for preterm labor home care. Okay, so which ones, trying to get this up here, which ones are a good plan? What is indicated and what is non-essential in this group? These are kind of like a next gen style question. You'll be given a case and you'll have different things. They're going to ask you different questions. So this is one. Now that we have a case, we know what do we want to teach her to do? What is essential? What is indicated in this list? What would you want to teach your client?
The second one.
Okay,
The third and fourth one. The sixth one.
I think that's good. Those are things we probably would want to teach. Kind of be, like the need for assistance in case she does go into labor so that she's not overworked. Okay. We don't need to have her monitor her vital signs. That's not essential. And we don't need to worry about a high protein diet. We just want her to eat what she's been eating. Okay. Good. So care plans, need for healthy teaching related to the recognition of signs and symptoms of preterm labor, potential injury related to the recurrence of preterm labor, and anxiety, definitely. So we need to address all of these things in our care plan. So this is a next gen style. That's why I really like to do case studies, because they progress through a pregnancy or a scenario, and you have to choose, what would you see? What would your interventions be? Okay. Does that make sense? Okay. So we still got another half an hour of class. So do you want to start working on something to prepare for your exam? Would you like to do that next for 30 minutes? So what do you think, as far as all the concepts that we've discussed? I know you're thinking, I don't remember any of them. What do you want to talk about?
The one that's most prevalent on the next exam.
Okay. And what is that?
I feel like you could let us know.
You do?
Yeah.
I can't tell you. I can't tell you. Let's see. See, where is my Zoom? Okay. So I went to the announcements here. exam 2 study sessions and PowerPoints, and you see what all is here. So this is what we're doing. I haven't put up the recording from Professor McGuffey yet, but she has done that, and I'll put that in here. We've got the PowerPoint. There's just the overall PowerPoint of all of everything. And then the comprehensive, the book that I gave you some ideas with meds and stuff in it. And then these are all the little videos that the instructors have done. We could look at this PowerPoint to start with that I did. Have any of you looked at this? Have any of you looked at this PowerPoint that I did? As soon as it opens up, this one, the diabetes one, nobody's looked at that. Okay, so here's another case study. So we're talking about diabetes, okay, first to start with. So Adriana is 32-year-old married Hispanic woman with 1 child. She comes into the clinic today with her 3rd pregnancy. During her very first pregnancy, she was 28 years old, so that was 4 years ago. She developed gestational diabetes, okay? And she actually had to begin some medication to control her blood glucose. Make sure you know what the target levels are. Euglycemia means good blood glucose, okay? So what are the target levels, okay? So know those. So during that first pregnancy, she delivered a preterm baby at 36 weeks. Okay, and that's the child she has now. Okay. So when she turned 2 years later, when she turned 30, she was diagnosed with type 2 diabetes. Okay. She had gestational, 2 years later, she developed type 2 diabetes. It's called pre-gestational because she's going to get pregnant again. Okay. So during her second pregnancy, she was a diabetic. Okay. Apparently, she did not have euglycemia. She did not control her blood glucose. So she had a lot of hyperglycemia, and she delivered a stillborn baby at 33 weeks. So now she comes into us at 32 years old, so 222, and she's pregnant for the 3rd time. What do you want to know? She's sitting there. You know her history now. You've talked about her history. What is your care plan for her? What are you concerned about? Her history. She's a diabetic. What do you want to know? She's sitting right in front of you and you're just sitting there.
Check
What
her
would you ask?
sugar, her blood pressure, and the baby's condition. I'm
Okay,
just-
we don't know how far along she is.
I don't know. I'm just participating, guessing. I don't know.
Good. Well, that's a good start. Good start. So her blood glucose, does she check it? What does it normally run? Is she on any medications? Things like that you want to know, right? You might also go into the psychological aspects. You have to keep that in mind. There might be some fear here because she lost her last baby, stillborn. Okay, so it's really important that you ask her how she's feeling about the pregnancy. Okay, how do you feel about this pregnancy? Because there's a 50% chance that it wasn't planned, right? So you need to make sure you're asking those questions. So you're concerned about her health status as well, her psychological health status here. We want to make sure she's beginning to check her blood glucose on a regular basis. We want to talk to her about her intake and all that, okay? This is not an uncommon scenario. This happened to me a lot when I was living where I was living before. That between pregnancies, a client becomes an actual diabetic. No, the history of gestational means that there's an increased risk that that client will actually develop type 2 diabetes within 4 or 5 years after that pregnancy. Okay. So pre-gestational diabetes means they have diabetes and then they get pregnant. So when you have a diabetic, they're already compromised by their metabolic system, the way it works now, the tendencies to be hyperglycemic. When you superimpose a pregnancy on top of that, it makes matters worse. Okay. So usually at the beginning of pregnancy, it's not concerned. It's after that 20th week, the diabetogenic state kicks in. Okay. So as insulin resistance increases during that second half of pregnancy, then we see the effects on mother and baby getting larger, lots of fluid. And that's the problem. Early on, though, we're at that first trimester, what are we worried about if our client is hyperglycemic? What if Adriana shows up at 8 weeks pregnancy and she said her blood glucose is never normal? What is your concern?
What's her diet? Oh, I don't know.
Well, hyperglycemia in that first trimester during organogenesis. What are you concerned about?
Is it congenital anomalies?
Yeah, hyperglycemia can cause congenital anomalies in that fetus, definitely. Okay. So let's talk a little bit about the differences between pregestational and gestational, or diabetes type 1, diabetes type 2, and gestational. So diabetes type 1 and type 2 is diagnosed when an A1C is 6.5 or greater. Okay, it's an average of blood glucose. It's an average of glucose on the hemoglobin molecules on the red blood cells. Okay, and this is a common lab that we do for diabetics every 3 months. Let's see how you're doing. Okay. During pregnancy, we want to know now what's going on. We don't want to know what's been going on for 3 months. I want to know right now what's going on with her. I want her to be aware of how she eats and how it affects her blood glucose. I want her to be aware of how her pregnancy is affecting her blood glucose. Okay. So gestational is only is diabetes only during pregnancy. Okay. And it occurs after 20 weeks. If she is pre-gestational, if she has type 1 or type 2, she doesn't have gestational diabetes, okay? If she has gestational diabetes, she doesn't have type 1 or type 2. It's just occurring during the pregnancy. Once that pregnancy is over, then so is the diabetes. Okay. So what lab is more appropriate and more accurate during pregnancy to monitor blood glucose? Because we have to be so strict during pregnancy. She can go into diabetic ketoacidosis at 200 milligrams per deciliter. So which one of these do you think is the best way to monitor her glucose during pregnancy? An A1C or a glucose monitor or a blood draw?
The glucose monitor.
Yeah, because I can stick your finger and I can tell you what your blood glucose is right now, which is what we need to know, right? A1C doesn't tell us today, it tells us history. Okay. So insulin needs then again the beginning of the pregnancy, what it's been. Between weeks 13, between 7, 13, 15, it actually drops down. The need for insulin drops down. So we might have to make some adjustment to a pre-gestational diabetic client. Okay. But once that 20-week mark hits, that's when the cells begin to resist insulin. It takes more insulin to open up that cell to let the sugar in. Okay. It's called a diabetogenic effect. Okay. And we have this resistance to allow for more of that glucose that's being circulated to get to the baby instead of mother. Okay. So that continues to increase until the baby is born, and then it drops off. Okay. It's called insulin resistance. Takes more insulin to open that cell up. So we have to then, with our diabetics or even with our gestational diabetics, have to increase medications or start a medication for a gestational. Some women develop gestational diabetes and all they need to do is change what they're eating and do some exercise to prevent having to take any medications. But there again, it's those clients that really need to be checking their glucose several times a day. Okay, so now that you understand a little bit what's going on, pathophysiology of hyperglycemia, this is a care plan. So client education, supporting your client, specialist referrals, fetal surveillance, labor care, what's the plan, and then postpartum. So we need to teach her signs of hypo and hyperglycemia. That means you need to know. Okay, that's in your text on page 244, I believe. In chapter 11, we have to tell her her glucose targets, what they should be. So you need to know these. An hour after she eats, it needs to be less than 140. Fasting, when she gets up in the morning, 2 hours after she eats, less than 120. Okay. Okay, so fetal surveillance, let's jump over. Fetal surveillance, we're keeping an eye on the fetus during her pregnancy. So we're talking mainly late second trimester and especially third trimester. So these clients, we need to watch baby's growth, right? Fluid levels. So we do ultrasounds every other week or every week, depends. We do biophysical profiles, BPP. It's an ultrasound that we're measuring certain parameters. We want to see the baby's reflexes. We want to ascertain the muscle tone, the amniotic fluid level. And then is the baby practice breathing? So there's 4 parameters. And we usually say 2, 4, 6, 8, 10. 2, 4, 6, 8, sorry. Okay, and then we can do non-stress tests. So this is a way of just keeping an eye on the fetus. Teaching mother, is your baby moving? So we know now that our expectant labor plan is all the complications that can occur with a large baby of a diabetic mother. Can we deliver vaginally or do we need to do a C-section? And then all the things that can occur postpartum. We want these babies to breastfeed within an hour of delivery so we can avert hypoglycemia in that newborn. Look for signs and symptoms in the newborn of respiratory distress. And then talk about, progestin-only contraception before she goes home. Okay, so we're going to review this a little bit. Hyperglycemia, the effects. For the diabetic client, you have the role of educator and coach. So let's talk to you about the effects of short-term hyperglycemia in pregnancy. what can happen? Well, she can go into ketoacidosis very quickly. Polyhydramnios, preeclampsia, placental abruption, gestational hypertension, labor dystocia, injuries, postpartum hemorrhage, infections, blood clots. Those are the short-term problems. Long-term diabetes, for those who have diabetes, type 1 or type 2, damaging the cardiovascular system. Okay, long-term hyperglycemia, which you'll learn about when you learn about diabetes, if you haven't already. And here's just the trail of what goes on when a client goes into ketoacidosis. Hyperglycemia upsets the osmolality of the blood. And you don't have to know that for testing purposes. So once again, hyperglycemia in the early antepartum, congenital disorders of the fetus. A lot of times it's a cardiac anatomy issue, limb deformities, spontaneous abortions. Most of the diabetics we take care of in a pregnancy are gestational diabetics, because type 1, type 2 might not be able to carry a pregnancy if their glucose isn't controlled. Okay. And then, of course, late antepartum, labor and birth. These are the things that you might see. Extreme prematurity. And then I have a little bit in here about substance use disorder. Remember, and I read some care plans or in the teaching plans last night. It was really good to see, because most people don't pick it. This student chose a mother that was on a antidepressant medication, not any alcohol or any opioids or anything else. She was on a medication for depression. And yes, we do need to be careful about those clients as well, because the baby is used to that. And once that baby is born, it might not be evident, depends on what medication. It might not be evident right at first, but the baby could have some signs of tachycardia or something else that is causing withdrawal from that antidepressant. So that was interesting. So we definitely want those babies to breastfeed. And then, of course, opioid withdrawal in a newborn. So for these mothers, definitely we want to try to get them into a rehab program to get them off of their opioids and get them onto something that's safer. And Suboxone or buprenorphine is the most safe. It's much safer than methadone. Okay, so if she's being compliant with these drugs here and not using any other prescriptions for opioids or any other street drugs, then we definitely want her to breastfeed. So the difference between methadone, why is buprenorphine much safer? Because it's only a partial agonist. Okay, it doesn't produce that heroin rush. It satisfies the cravings for opioids, but buprenorphine in particular reduces dependency, okay, which is what causes a withdrawal. So it is a good option for our pregnant clients who are used to drugs. And then another thing I was talking to a student about today is, don't forget that postpartum blues and postpartum depression, usually the postpartum blues occur first. If they continue on and they don't resolve, then we're thinking more it's a depression. Okay, it persists longer, so she needs some help. And some things you might see in a depression, like anybody else, losing interest in day-to-day life. You don't have an interest in doing things that you used to enjoy. Okay, not really taking care of yourself. yes, you might become suicidal. It doesn't mean you're psychotic, infanticidal, homicidal. It just means you have some depression going on and you're trying to deal with it. It doesn't mean you're psychotic, okay? The difference,
So if you have indications of self-harm, that's still PPD and not psychosis?
yeah, the differentiating thing about psychosis is that it's bizarre, impulsive behavior, delusions, hallucinations. And this is what we usually see in someone who has a history of bipolar or some other kind of mental health disease. But they also might become suicidal. Okay, so it's not one or the other. I think that's one thing that I've seen in the past that students didn't understand.
Yeah, I guess I thought that the psychosis was specifically directed towards either self-harm or harming the baby.
No, that's not how it's not defined medically. It's the bizarre impulsive behaviors, almost like out of touch with reality. Okay. And why aren't you turning your video on, Gail? Gail,
Yeah, I'm here. I
what?
don't have Wi-Fi where I am, so I can't use my computer, so I'm on my phone, but my camera doesn't work on my phone still. I
You're gonna
emailed you. Did you get it?
just recently?
I emailed you like 40 minutes before class started.
Okay, okay. No, I haven't looked yet, but okay. So just know for the exam, you're not gonna be able to take your exam unless you have a working camera.
Yeah,
So
I can get Zoom, the camera to work on my computer. I just can't get it to work on my phone. And I'm not sure why, because the last term I was able to do it and it worked fine. I've tried my settings in the app, in on the website, on my phone. I'm not sure what I've done, but I just can't figure out, like, whenever I try to turn the camera on, it just says that I don't have access to it.
Oh, so you need to give Zoom access. You need to probably talk to somebody on campus to get that fixed this week.
Okay.
Okay. Yeah, because I don't want you to not be able to take your exam next week. Okay.
Well,
Okay.
this was just kind of a today thing. So next week I'll have my computer and I'll be where I have Wi-Fi.
Okay. Okay. That sounds good. Okay. Anything I can help anybody with after I went through all of that? So try I'm having a drop-in tutoring session Thursday afternoon. If you come up with something between now and then that you want to talk about, come to Zoom. Okay, I'll be here Thursday afternoon between 1 and 3. I don't have any classes or anything then. And then Dr. Roberts has several drop-in tutoring sessions this week. So feel free to join her Zoom sessions. And that's in the announcements. Okay. And try to go to one of the live sessions. Okay, so it gets you prepared for the exam. Okay. All right. Well, I think we're finished. Still a few minutes early, but that's okay. So have you decided how you're preparing for exam 2? What are your plans? You know, are you going to you need to plan it out, okay, and not just hope that you remember everything, okay? So think about, I don't want you just doing a bunch of NCLEX questions and nothing else. You need to use the resources that we're giving you, okay, to study, because all those little short videos that the instructors are giving you cover all the concepts. So if there's one that you're not sure about, watch that video and learn from it. So I want to encourage you that usually this exam is a little bit easier for everybody. So I do expect you all to do very well on it. Okay, if you're preparing, you should do well. Okay. All right. Any questions?
No,
Then we can wrap it up.
we're dismissed.
You're dismissed. Yes.
Thank you.
And bye, Annie. I see two people still. Sarah, do you need something else? Sarah? Are you asleep? Sarah? I think Sarah's asleep.